Mute yourself so we can have the proceedings in peace. So, a very good afternoon, everyone, all our faculties, all the seniors who joined us today, and all the viewers. Today, we begin with the first episode of our webinar, The Clinical Pearls of JOGI, which is the brainchild of our AIC, Dr. Madhuri Patel. I would like to call upon our AIC, Dr. Madhuri Patel, to give the welcome address.
Thank you, Pragna, for your kind words. Respected our President, Dr. Jaideep Tan, and today's chief guest, and my mentor, Professor C.N. Purandare, chief guest and editor emeritus, Professor Dr. Adi Dastu, Dr. Suvarna Khadilkar, Dr. Geeta Basarkar, our editor emeritus, then our chairperson, Dr. Sujata Dalvi, associate editor of our journal, national editor, Dr. Krishnendu Gupta, and Dr. Lakshmi Shrikande. Our editorial team, Dr. Arun Nayak, Dr. Anayata.
So I now request Dr. Rachna, who is the medical disorders committee chair.
Can you mute yourself? Okay. Then our editorial team, Dr. Sujata Dalvi, Dr. Arun Nayak, Dr. Anayata Chavan, Dr. Ashwini Balerao Gandhi, Dr. Pragna Changle, secretary team, Dr. Pragna Supe, Dr. Gaurav Desai, and Sunil Tambewatkar. And of course, I must also invite our national corresponding editors. Apart from Dr. Krishnendu and Dr. Lakshmi, there are Sushil Chawla, Dr. Radhika, Dr. Kiran Mai, Dr. Shobha, Dr. Dipti Gupta, Dr. Mala Srivastav, Dr. Alka Pandey, Dr. Madhava Sir, Dr. Shampat Kumari, Dr. Ashok Kumar, Dr. Ramni Devi, Dr. Subhash Chandra, Dr. Nidhi Gupta, all our reviewers and dear friends. Very good evening to all of you. It is with a great pleasure and anticipation that I welcome you all to the inaugural webinar of FOGSI JOGI, Clinical Pulse of JOGI, an initiative by our JOGI team. As the editor-in-chief, it is honor to introduce our esteemed speakers whose insightful article is published in our reputed bi-monthly journal, JOGI. This time we have selected 2 original articles and they have received the first prize in the senior category, Dr. Pragna Changle, who is in our editorial team, and Dr. Vijayasri. She has also received second prize, and we have invited her because the first prize winner is not in town, so we'll introduce her in the next meeting. So now with this, I would like to say that this new introduction of Clinical Pulse of JOGI will provide us opportunity to understand the article the way author has put to us, and we will have discussion with the authors directly. And so many of our young budding gynecologists who are doing residency, they can pick up these topics and they can do themselves also research on that. Then I am really confident that initiative will immensely benefit the aspiring contributor. And now I invite our President, Chief Guest, Dr. Jaideep Tan, to say few words on this, clinical pulse of JOGI.
Thank you very much, Dr. Patel. I hope I'm audible. Am I audible?
Yes, sir.
Yes, sir.
Yes.
We can hear you.
Thank you. Thank you very much, Dr. Patel, for putting this very important webinar together. I must congratulate you. I'm sure it's not easy wearing the multiple hats that you wear.
Jaideep,
Yes,
can I excuse me? Can we have Saraswati Vandana or something before?
Yes, of course, madam. Of course.
Voice is not coming. Maria?
Om Saraswati Namo Namo Saraswati Vidyadayani Namo Namo Hansavahini
Thank you, Dr. Pragna and Dr. Maria, and both Pragnas. Jaideep, may I request you now to say the few words for this program?
Thank you very much, Dr. Patel. I know it must not be easy for you. You're wearing two very major hats as the EIC and also as the Secretary General of FOGSI. Perhaps we can switch off screen sharing so that I can see everybody. Thank you. As I said, it must not be easy for you, Dr. Patel, wearing two major hats, the EIC and the Secretary General of FOGSI. But I must say you're managing it very admirably. So thank you very much for all the work that you do, and many congratulations on all your excellent efforts. It is my privilege to be a chief guest in a webinar where the chief guest is Dr. C.N. Purandre. We all know, sir, I think his influence over us and the institution of FOGSI is undoubtedly huge. And it is always such a pleasure to learn and meet sir. And every time you meet sir, you learn something new. So thank you very much, sir, for all your advice, guidance, support, and advice over the last so many years. It's also a pleasure to see the chairpersons, Dr. Sujata, Krishnendu, Dr. Lakshmi, and I'm sure that your entire team is going to take the journal to much bigger and better heights. Thank you very much, Pradnya. And I'm not going to specify which one because both have been working very hard. So thank you very much, Pradnya. And of course, congratulations to the speakers who have been chosen. Here I will say Pradnya Chengade and Dr. Vijay Shri. And of course, thank you very much to the office staff within FOGSI. I know that they work very hard for the journal. And indeed, I can say that the journal is our pride, and we hope that the journal goes from height to height. Thank you very much again, Dr. Patel, for this initiative, putting this together. I'm sure it will serve a very important purpose, not only of highlighting the magnificent articles that are published in the journal, but also incentivizing authors to publish in the journals, because then they get a platform, one more platform to talk about their publication. Thank you very much again.
Thank you, Dr. Jaideep, for your kind words. And one thing I will say, Dr. Jaideep, when I talked to him that I want to start this series, so he accepted immediately and he was very happy. The authors usually they present their work in the conferences and all, and many of the people, they are not there over there to listen to them. So this is another platform where they can present themselves, and this is an opportunity for them. And our budding all the gynecologists will also get a chance to present on the FOGSI platform. So thank you, Dr. Jaideep, for joining once again. And now I request my mentor, Professor C.N. Purandare. I will learn not only nitty-gritty from him about the FOGSI administration, and also from Jaideep and Rishikesh, but also about as an editor-in-chief today, what I am today, that I have learned many things from sir. And I request, I'm really blessed. Whenever I ask sir, sir is always there, and I'm really, fortunate, and I'm blessed that sir is always there for the program. Thank you, sir. Now I invite you to say a few words, sir.
Thank you very much, Madhuri. And when I look at this program, I thought that it's one phenomenal thing that's going to happen, and I think compliments to you for thinking about it, because most of the time we give awards which are on the dais at the AICOG, where people are just walking in and out, and hardly anybody giving any attention to what is happening, just taking a photograph with a plaque, and that's it, they're the best paper, and so on and so forth. But I think this platform will give chance to the best paper people to give their paper outlet to so many people in this webinar. And the senior category as well as junior category, when not only getting a chance to speak in, but question answer, which is very important for any scientific paper, that you get comments and you answer to what you have achieved in the publication that you have. And
in a year, and we can only publish 100 to 110 public original papers. So our selection rate is only 10%. That means 85 to 90% papers are rejected. And what happens, sir, out of these 100 papers, the award-winning papers we have selected this time, and then once, after that we'll be selecting the good articles with the editorial team. They will be presenting those articles. So these are the articles which have been selected out of 1,100 articles. Out of these people, 3 in a senior and 3 in a junior category have received the awards. Those will be presenting first. Then we'll be presenting the papers which Springer has given the award, and then we'll select the good articles. So these papers are really good, and I feel everybody should enjoy and give the chance to the author to explain from their side. Thank you, sir. Now I request our MOC for the further proceeding.
Yeah, thank you, madam. I would now like to call upon our chairpersons for today. Can I? Just a minute. Can I be unmuted, please? So our first chairperson is Dr. Sujata Dalvi. Madam is consultant obstetrician and gynecologist attached to various hospitals such as Global, Saifi, Bhatia. She is also the associated editor of JOGI. Welcome, madam. Our second chairperson for today is Dr. Krishnendu Gupta, sir. Sir is professor and unit head Department of OBGYN, Vivekananda Institute of Medical Sciences, Kolkata. Sir is also FOGSI representative to Asia and Oceania Federation of Obstetrics and Gynecology. Sir is also a national corresponding editor of JOGI from 2024 to 26. Welcome, sir. Our next chairperson is Dr. Lakshmi Chirikande. Madam is immediate past chairperson of ICOG. She is also the national corresponding editor, national corresponding secretary of AMWI Association of Medical Women India, also the president of ISOPAP Vidarbha chapter. Welcome, madam. I now request our chairpersons to introduce our first speaker, Dr. Pradnya Changede.
Yeah. So good afternoon, everyone, and thank you, Pradnya, for giving me a nice introduction. At an outset, I would like to thank and express my gratitude to Editor-in-Chief Dr. Madhuri Patel. She very subtly said that this was an initiative of Clinical Pearls of JOGI. The inaugural session is an initiative of a JOGI team. Actually, mind you, it is her brain, and we have all supported it. So the whole credit goes to EIC, Dr. Madhuri Patel. I would also like to acknowledge the words of wisdom given by our chief guest, FOGSI President Dr. Jaideep Tan, and Dr. C.N. Purandare, FIGO and FOGSI President and Emeritus Editor of JOGI. So before we start our session, I would like to introduce our first speaker, that is Dr. Pradnya Changede. Pradnya Changede is an Associate Professor of Obstetrics and Gynecology at LTMC College and Sion Hospital, and she is also a second joint assistant editor of JOGI, and her paper was on causes and demographic factors affecting stillbirth in a tertiary care center in India. And this paper got a first prize in a senior category. So we would like to listen in from Dr. Pradnya Changede, her experience and what made her write on this topic. So over to Dr. Pradnya Changede.
So thank you, respected chairpersons, Dr. Sujata Dalvi, Dr. Krishnendu Gupta, Dr. Lakshmi Chirikande for the kind introduction. At the outset, I would like to thank FOGSI President Dr. Jaideep Tan, sir, the Editor-in-Chief of JOGI, Dr. Madhuri Patel, Madam, who is also the Secretary General of FOGSI, to start with this initiative called as Clinical Pearls of JOGI. So it is every FOGSian dream to be publish an article in JOGI, and I was fortunate enough that I am attached to a very elite hospital of Mumbai, Lokmanya Tilak Municipal Medical College. And as a nodal officer for stillbirth, I got an opportunity to scan all the stillbirths which were delivering at our hospital, and ours is a tertiary referral center. And with this data, when my paper was accepted, little did I know that it would be put up for jury review and I would get the first prize. So people have won before this, but it is Dr. Madhuri Patel madam's brainchild and idea that she started with this initiative where the authors themselves get a platform to present their hard work, and this also helps the author, their hard work be known to all over India, all the budding, aspiring, the researchers, the writers, and I'm sure these papers and all such programs will make you aware how to write papers and how to get your work published. And I really thank you, madam, for giving us an opportunity to present this. And we had actually going to present all the prize winning papers. So keep in mind, every third Wednesday of the month we are going to present, and all the prize winning papers in JOGI and good articles, they will be presented to you from the authors, so that if there are questions, if any, or any suggestions, they can be taken into account while writing new papers. So thank you so much. With this, I will begin my presentation. So can everybody see my screen? Yeah,
Yes.
so this was my paper. It was titled Causes and Demographic Factors Affecting Stillbirth in a Tertiary Care Center in India. This was published in the May-June issue of JOGI 2022. So 72nd volume, the third issue, and the page numbers were 225 to 235. So DOI number, so this is just for the authors. I would like to know that DOI number helps you search, which is a digital object identifier. So you can search a paper if you know the number. So this is a work done at Lokmanya Tilak Municipal Medical College and General Hospital. We had a 75th anniversary last year, and it is one of the busiest hospitals in Mumbai, and we cater to around 9,000 to 10,000 deliveries every year. It is one of the busiest. It serves Asia's largest slum, which is Dharavi, and we have a lot of high-risk registrations at this center. And my co-authors were Dr. Sneha Venkateshwaran, Dr. Arun Nayak, Dr. Dinesh Pade, Dr. Priyanka Sonone, Dr. Ruchita Patel, and Dr. Hitendra. And as you can see, this was done under the guidance of our head of department, Dr. Arun Nayak. He is the head and professor at our medical college, and this was my paper. And this is the abstract, and you can see the serial numbers, and this was it underwent revision. So when authors get that we submitted our paper 5 months back, 3 months back, and they get very agitated, it takes time. So I had submitted in April, and it got and it always makes your paper better. You feel that you've got a revision, but mind you, that revision really enhances the quality of the paper. So this is the designation of all the authors that were my co-authors for this paper. And so we did this was a prospective observational study, and we all know that the annual estimated rate of stillbirth worldwide is 2.6 million per year. And we know that 98% of the stillbirths come from low and middle income countries like India. And stillbirth is known as a silent epidemic. And in addition to this, the bereavement care in our country is often neglected. So we need focused interventions to reduce this burden of stillbirth. So how can you reduce the stillbirths? Is when I was made in charge, I realized that unless we know what causes the maximum number of stillbirth, we cannot do any changes, or we cannot suggest to the healthcare facility or the community at large that what factors can be changed, antepartum, intrapartum, and why. That is the causes, risk factors, and contributing factors. So the health status of a population can be gauged by the stillbirth rate, and it reflects the quality of antenatal and intrapartum care. And we all know that India's stillbirth rate as given by WHO is 22 per 1,000 total births. And India ranks highest in the world in terms of absolute number of stillbirths. And this is not a good thing. We want to lead in other areas, but not in the area of being first in stillbirth. And we have a long way to improve. So how do we improve? We can improve pregnancy care, promote institutional deliveries in high-risk groups. And one of the goals of the India Newborn Action Plan is to reduce stillbirths to less than 10 per 1,000 births by 2030. So we still have a long way to go. So what we did is, WHO has given international comparison definition of stillbirth as the one with 28 weeks of gestation or 1,000 grams. The RCOG has defined stillbirth a baby born with no signs of life after 24 completed weeks. The ICD-10 takes it as 500 grams or 22 weeks. So how do we calculate the stillbirth rate? It is defined by the number of stillbirths per 1,000 total births during the year. In India, we have 592,100 deaths per year. India is leading the world in the stillbirth rate. And hence, worldwide, if you see, the stillbirth rate is 24.7 in 2000. Worldwide, it is decreasing to 18.4. In India, it was 33 and we have brought it down to 23. But still, if you take the figure of 10, we have a long way to go. So to this, and as we cater to a very high risk population where we have a lot of referral cases, where a lot of high risk registrations, with these aims and objectives, we started our study. So the objective of our study was to review the causes of stillbirth, and we wanted to classify the causes. So there are various classification systems that are available, and we use the RECODE system of classification, which is maternal, fetal, and placental causes. And we wanted to look into the demographic factors also, because they play a major role in reducing the burden of stillbirth. So using this data, the areas of action can be identified. We can determine the causes and contributing factors. And by knowing these factors, of course, a preventive strategy can be formulated. So this was a prospective observational study, and we use a criteria of 20 weeks and 500 grams baby weight. And this was done at Lokmanya Tilak Municipal Medical College. And all the stillbirths from 1st Jan 2019 to 31st December 2019 were included. So we took a 1-year data, and the exclusion criteria was all live births. So what we did was all the stillbirths occurring during this period were enrolled, and all the patients who were willing to participate in the study were enrolled. All those who did not want to participate were excluded. And we took the labor room record, the antenatal ward, all the patients who were admitted, or even from the outpatient records, we took a detailed history, demographic details, obstetric history. We recorded the labor management details, and all the data was collected by history taking, scrutinizing antenatal records, transfer summaries in case of referred patients and during hospital stay. And after the birth of the stillborn, what is called as a verbal autopsy, we examined all the babies externally to look for evidence of maceration, and then we classified it as macerated birth. Gender, birth weight, gestational age, and of course we have a team. We have monthly stillbirth meetings, and a probable cause of death was assigned to such cases, and a RECODE classification was used. So the maternal demographic details like age, place, socioeconomic status, education, obstetric history, the place where she was antenatally registered, number of visits, history of prior losses, probable cause and time of death, which was if it was antepartum or intrapartum, and the most relevant condition of death was taken into account. So the data was collected and tabulated, and these were reviewed by experts of neonatology and obstetric gynecology. And if there was a lapse in care, it was noted down, and suggestions were given to all those concerned to prevent occurrence. As this was a qualitative data, we have mentioned all the results in percentage and found the maximum number of stillbirths due to a particular cause by percentage. So we had a confinement of 9,074 deliveries, and we had 8,799 live births. So we scanned a lot of patients, almost more than 9,000, and we had 8,799, and out of that 275 were stillbirths. So as per the records in the confinement register, 113 were fresh stillbirth and 162 were macerated stillbirth. So the stillbirth rate at a center was 30.3 per 1,000 births. And as we had 3 pairs of stillborns, so we collected data for 272 mothers. So this is very important to write, and I think as a reviewer also and as editor, when we get a lot of numbers, we get articles which are big, but the numbers do not add. So please, when you are writing, it is just a suggestion, you should account for all the deliveries if it were excluded, so that the data should add up. So if you see the charts, you will see that most of the patients were between 18 to 25 years. Most of them were urban. Of course, we had a few, 4 were referred from rural areas. Maximum were illiterate. So as we are catering to Asia's largest slum, Dharavi, most of the patients coming to a hospital, almost 35% were illiterate, and the upper lower economic, socio-economic status was there. So if you see the Asian numbers, so this is another chart, and we can see that 268 were the urban. If you see by visits and by gravida status, most of them were primary gravida. So 85% patients or 31% patients were primary gravida. 73 were from our hospital. But if you see other hospitals, they referred us almost 177 patients, because we are a tertiary apex institute, and where high-risk patients cannot be delivered, or cesarean facilities are not available, or blood, fresh frozen plasma and other blood products are not available. So we had a lot of referrals also. You see, even in spite of being in the city of Mumbai, 45% patients had less than 3 antenatal visits. So they didn't have. 45 patients had history of stillbirths. 5 had a first trimester miscarriages. And late neonatal deaths were 2. And first trimester miscarriage and stillbirth were 2. So you see that this stillbirth recurs in a lot of patients. If we consider the gravida status, 85%, as I told you, were primary gravida. 70 subjects were in their second pregnancy, and 66 and 37 were in the third and fourth pregnancy. So if you see that one, as I told you, that less than 3 so all the patients should be advised for regular antenatal visits, and they should be emphasized. They and their family members should understand the importance of an institutional delivery, following all the antenatal advice. So if you see, this is a gestational age in weeks. So maximum, so almost 84 cases occurred after 37 weeks. So if you see, most of them were preterm. Next highest group was 28 to 32 weeks, and the third highest was 55 number. If you see the sex-wise distribution of the baby, we found that more male fetuses. So this is known by a lot of studies that the female fetuses withstand a lot of intrauterine growth restriction or adverse effects. So we had a lot of male babies who succumbed, 148. The type of stillbirth, 162 were macerated and 113 were fresh. So if we see this, we come to know that 61 had loss of fetal heart during labor. So I think this could have been prevented. These are intrapartum stillbirths. So with strict fetal heart monitoring, we can definitely prevent. And but if you see that 57 of these mothers were referred to a center in labor, and when we actually assess, most of them had a delay in referral to our tertiary center. So referral linkage here, I would like to conclude that we should have a good referral linkage where, early ambulance, early transfer of patients. In Mumbai, we know there are a lot of traffic jams, and sometimes patients are left on their own to find means of transport. So that could have led to a late transfer. If you see the birth weight wise, you can see that we had a lot of 17% we had in the 2 to 2.5 kg, 18% we had 1.5 to 2 kg, and the maximum were of course up to 999 grams. So weight also contributed to stillbirths. So if you see, 64 babies, 999, and 49 babies and 48 babies. So most of them were between 1.5 and 2.5. And it was only 3% babies who weighed between 3 and 3.5. So that is the structure. If you see the causes of stillbirths, we found that 115 of these had maternal causes, 84 were fetal causes, 56 had placental and cord and liquor abnormalities, and it was unknown in 20%. So the probable cause of stillbirth was, so you can see there is always an overlap of factors. But what we took in our study is we took the most significant contributory factor. So you can see maximum were due to maternal causes. When we analyzed the maternal causes, we found that hypertensive disorders of pregnancy and its consequences accounted for 66% of these stillbirths, and other medical causes were 29%. So if you go to see that hypertensive disorders in pregnancy, they can cause stillbirth. So regular BP checkup at every visit, taking urine albumin, insisting the patient to get hospitalized or for BP monitoring. We can also start antihypertensive. So if hypertensive disorders can be controlled earlier, it can prevent so many stillbirths. 34 cases were to medical disorders and 5 were due to miscellaneous. So diabetes was seen in 11 mothers of stillborn babies as the primary, and severe anemia was found in 4 mothers. And of course, there was no maternal mortality in these anemic mothers. So if you see, in hypertension also, maximum were due to very severe preeclampsia and severe preeclampsia with abruptio placenta, and 11 were associated with IUGR and Doppler changes. So if you see the other maternal condition, diabetes tops the list. Next was fever, and the third was severe anemia, and the fourth was rheumatic heart diseases and renal disorders. So as we see that heart diseases, many patients with heart disease are now conceiving, but if it is not a favorable intrauterine environment, if we study the fetal causes, we found that fetal growth restriction topped this. So almost 30 cases or 36% we found. So total we had 84 cases. Prematurity was in 11 cases. 25 stillborn had structural malformations. So they should have been offered termination if they were incompatible with life. And now with the MTP being done up to 24 weeks, we surely can offer medical termination to these patients who cannot be, salvaged. 56 cases were due to placental cord and liquor abnormalities. So you can see abruptio placentae top the list, followed by meconium stained amniotic fluid and polyhydramnios PR. So why did we use the record system? Record system is used. So by using this, I will just come to that. So if we study, the major cause of stillbirths was hypertensive disease in pregnancy, followed by fetal growth restriction. So what is a record system? Is first you go in a structural hierarchy. You rule out the fetal causes, then in umbilical cord causes, then the placenta, then the amniotic fluid, then the uterine, then the maternal, then intrapartum trauma and unclassified. So if you go in this stepwise manner, how record helps is it gives the cause most of the times. So when there are other classifications, this is the distribution which is showing the record classification. So you can see the maternal causes, which is hypertensive disorders, and in the fetal growth restriction is dropping. So this was a paper, which was given in 2005, where the record was introduced by Jason Gardosi, and they introduced this system so that most of the stillbirths can be given a cause. So if you take group A fetus, then of course you have to rule out lethal congenital abnormalities, infections, isoimmunization, and so on. So all these are the different causes, and you have to rule out each, and only if you reach this group where the causes are unclassified, you will get. So there are other classifications by Wigglesworth. You have the fetal neonatal classification, the Aberdeen, the Whitfield, the Stockholm, the Nordic Baltic system, and the Perinatal Society, and the Dutch Tulip. So there are several of these classifications, and it has, several categories. You have almost 17 categories. Nordic Baltic system has 5 variables. The Aberdeen classification is there, and you can classify into all. But what was found with the other classifications was a number of stillbirths didn't have any attributable cause. So what happened is many remained in the unexplained group. So we had this fetal neonatal classification also. So you can see, so this was the entire abstract of the record classification. And how it is done is, you use this growth charts. So there are optimal weight related softwares, and they are available, and you calculate the fetal growth potential after adjusting for the fetus sex and constitutional characteristics. And then when we put it in this, we find that many stillbirths had stillbirths due to this restricted growth. So that is why we could attribute a cause to these stillbirths. So the actual birth weight is compared with the optimal weight gain which is predicted. And for missing data, the maternal height or weight at booking was considered. So there were various, so Wigglesworth, you have the pathological causes. So the Nordic Baltic system, what they used, they focused on potential avoidable perinatal death. There was a classification of perinatal deaths given by Australia and New Zealand. And they also took into account obstetric antecedent factors. But when we went through all the classifications, we chose the report because it identifies the relevant condition at the time of death. And we also had the Dutch tulip system, but it includes the stillbirths along with the neonatal deaths. And if you see, the reasons are different. So we have chosen this. So to discuss, there are several studies which resemble our studies. There was a study conducted in Chandigarh by Newton Raj, and they found that 68% deaths were antepartum and 32 were intrapartum. Then there was a study, they also found that in our study also we had almost the same, which was 77 and 22. There was another study done by B. Sharma et al. And they found that 60% had fresh stillbirths and 40% had macerated stillbirths. So depending on the region where you practice, depending on the setup, tertiary, primary, your results may vary. There is a study done in sub-Saharan Africa where 1,563 stillbirths were evaluated and they had almost 50.7 as an intrapartum cause. There was another study done by Sharma et al. And they observed 51,552 total births. And they found that there was many with less than the recommended number of antenatal visits. And most of them were referred, as in our case, 83% in their study. So again, when you compare, so there were different studies, the Southern India study by Kallur Shailaja Devi, they also classified the stillbirth by report. So this was one study which we found which was similar classification was used. And we found that they found that most of them, the leading cause of death was fetal growth disorders. So fetal growth disorders was the second cause in our study, but in this study they found it to be the leading cause of death. And hypertensive disorders was the second cause in the study. So this is just a summary of all the studies which are done. I presented it in a tabular form, wherein we have represented our studies and compared it with studies done elsewhere, which is done in Kallur. And then you have the Mahmuda study done in sub-Saharan Africa and the one done in Chandigarh. So if you look at the study, you find that depending on the place, the tertiary, primary, secondary, depending on whether you cater to registered, referred patients, and whether you have a fetal good monitoring system, trained staff for fetal heart sound monitoring, the causes of stillbirth are going to differ. So to conclude, I would like to say that most of the stillbirths in our study were due to maternal medical conditions, and hypertensive disorders of pregnancy was the most common. And mothers in the age group were 26 to 30. So better regulation of private healthcare, like building public-private partnerships, emergency obstetric care can be provided, better equipment can be given. And to reach the single-digit stillbirth rate recommended by WHO and UNICEF, we have a long way to go, and we should do a multi-partner initiative. So by various measures like patient education, counseling, doing antenatal registration, early diagnosis and management of medical disorders of pregnancy and fetal anomalies, and providing good interpartum fetal surveillance methods, establishing a good referral linkage which will facilitate early transfer of patients. And we should equip not only the tertiary centers, but even the smaller hospitals with more manpower and equipments. And this will go a long way in reaching the recommended stillbirth rate. So all the authors have contributed to the design data analysis, writing, proofreading, and we all take responsibility for this management. So these are the declarations which are recommended after every article. So the source of funding, we didn't have any source of funding. We had no conflict of interest. We have an ethical approval taken from our ethics committee, which we have duly submitted to the journal. And it has been approved by the Institutional Ethics Board. And we did this study in accordance with the Helsinki Declaration and its amendments. And these are my references. And with this, I would like to end my talk. And I'm really thankful to the FOGSI President Dr. Jaideep Tam, Dr. Madhuri Patel Ma'am, EIC JOGI Secretary General, respected chairpersons, for giving me this opportunity to present my prize-winning paper and giving me a platform to showcase our hard work done in Sion Hospital. So thank you so much for your patience listening.
Thank you, Dr. Pradnya, for giving absolute good explanation about your article and how you have gone about doing research and everything. Before I comment on it, I would like Dr. Krishnendu Gupta to comment on whatever Dr. Pradnya Chengede has spoken about her paper. Over to Dr. Krishnendu Gupta, please.
Thank you, Dr. Sujata. I think it was a wonderful presentation and, of course, a wonderful paper, noteworthy, getting such the highest prize of JOGI. We did hear Pradnya very recently in Calcutta during the PICSEF workshop, and she really showed her expertise as that. But before I actually go ahead, I would like to thank Dr. Madhuri Patel for this opportunity along with the entire JOGI team. And I must place on record my grateful thanks to Professor C.N. Purandare, because it was he who made a call way back in 2013. One evening I was relaxing in the house where I got a call, and he said that, why don't you join the JOGI as a national corresponding editor, and I became the first time in 2014. So I really owe a lot to Professor C.N. Purandare for this. Jaideep said a very beautiful word about Madhuri donning 2 hats, and I'm sure she's doing it with great elan. And but coming back to the paper, I think this is really an excellent study for people to learn from on how to, kind of reduce the incidence of stillbirths wherever possible. And I see Dr. Geeta Balsarkar's hand up, so I will definitely give her the opportunity as well, with a special thanks to her, because it was during her tenure that we as national corresponding editors got the opportunity actually to review articles, send it to editors, and then really move forward as an editor. Really the editorial job we got, and we really enjoyed it, and thank you, Geeta, for that. And Madhuri is doing such a great job, and also taking up these newer the clinical pearls, and to highlight the prize winners, and also to highlight the scientific pearls that is happening in JOGI. So over to Geeta, after which I think Sujata and of course our co-chairperson Dr. Lakshmi will also join in before our next speaker comes. Over to Geeta.
Yeah, thank you, Pradnya. That was a really wonderful study. I have, as an editor-in-chief, I have gone through this study very extensively, thoroughly, and she has got a prize also for this particular study. But Pradnya, as a member of the district control for Mumbai maternal mortality, I would like to point out that there are many stillbirths which happen when mothers die. Right from 20 weeks onwards, or 28 weeks, say, not every time there is a perimortem cesarean section that is done to save the baby. Some babies die along with the mother. Do you have any such patients in your study, or do you have any comments about this particular condition where there is a maternal mortality which is associated with the stillbirth?
So in that particular year which I had presented, we had no mortalities, but I have myself experienced when I was taking rounds and a patient's DMB was being done, and unfortunately, because of her high risk cardiac condition, she collapsed on the table, and there were no instruments that time. We just had a blade into artery, and actually I had gone ahead and done the perimortem cesarean section, and I'm very proud to say that the baby actually went home. So I think so delivering the baby when the mother is term, getting it out will facilitate giving good CPCR also to the mother. So all the efforts were made. Unfortunately, we couldn't salvage the mother, but it was a perimortem cesarean section. So I think so we should do it both for maternal and fetal interest, and not hesitate where required, because we can still salvage the baby. And had we just given up, that people fear medico-legally what will happen if I do, but I think it is given in all the guidelines that because the fetus is pressing on the diaphragm, you cannot administer good CPCR, like the cardiopulmonary resuscitation. So delivery of the baby definitely helps in saving the mother also. So I think so we should not hold back ourselves, and where required, it should definitely be done.
So if to propagate this message, we should do an analysis of the babies we have lost in this condition, at least from 28 weeks to 37 weeks in sudden maternal collapse, or in these conditions where they definitely could have been salvaged. Like you said, all that we need is a knife to deliver the baby.
Yes.
The rest of the things can be procured later on. And I am proud to say that I have done 3 such patients over a period of 27 years, and 2 of these mothers have gone home. One mother, of course, had an aortic dissection and she died, and all the 3 babies have gone home. So it is possible to avert such stillbirth in these cases, hence they should also be studied. And I'm really surprised at how in Sion Hospital in that 1 year there were no maternal mortality, or how they did not go. But often, as a member of the district control, I see so many babies being lost from 28 weeks to term, where nothing is done because consent is not there, patient arrested suddenly, we could not do anything. You can do it in the labor ward, or you can do it even in the antenatal ward. Really, OT is not necessary for this, but then yes, we have to have more studies on this to find out whether it is really worthwhile.
Definitely, ma'am, we will consider it. Actually, our hospital was undergoing renovation at that period, and we were taking, otherwise the confinement is usually more than that. So we should definitely look into that as a future prospective study.
Lakshmi, you can go ahead as a chairperson. And
Yeah.
Geeta, after Dr. Lakshmi's comment, I would like to ask you to tell all the our people who have joined that how the papers are selected for the best paper awards.
There are some questions also in the chat
Yes,
box.
there are that you can take up. You can take up, yeah.
I can't see. Yeah.
Lakshmi, you can take up the questions if you wish.
Questions are there. There are questions.
No, from mobile I shifted to the desktop, so I can't see any questions in the chat box.
Ma'am, I will read them at the end of my.
Yeah, 1 minute. 1 minute. Lakshmi, can you see otherwise Sujata or?
Yeah, I can. Can I read out?
Sujata,
Yeah,
please.
please.
Yeah, okay.
Please, Sujata, go ahead. Go ahead.
Yeah. So here there is a question that this 29 years old patient with an anomaly scan showing placentomegaly, her blood pressure was normal and she was advised blood pressure monitoring and watching for IUGR, but she followed it up suddenly with an IUFT and her BP was 140 by 100, urine albumin was 1 plus. They want to know what could be the possible cause, Pradnya, if at all it is possible. Her BP was normal, but then suddenly she landed up with an IUFD, and that time her BP was shown to be 140 by 100.
So here I would like to say that we need to dwell into all the causes. Like in a recode, you have to go in a stepwise manner. Find out now here the gestation has not been mentioned.
She said 29 weeks, and the sonography at growth scan showed only placentomegaly, nothing else,
But she's 29-year-old, I think.
Year-old, sorry. Yeah, she's mentioned it later. She's 29 weeks IUFD.
Okay.
So she just got a growth scan done and it showed placentomegaly, and after 2 weeks of that, she landed up having an IUFD.
So here comes I think we have to see whether the baby, so anomalies can normal doesn't always mean that the baby is normal. You have to still do a verbal autopsy. You have to see the baby, whether all the structurally abnormal. Examine the placenta at the delivery of the stillborn baby. See if there are infarcts, there are calcification, there are thrombos. You have to see the weight, the growth potential of this baby, whether this was growth restricted. And hence, as I mentioned in there are growth charts which are available. So depending on the baby could have had a potential for 3.5 and it could have still been lagging in that aspect. So you have to examine a lot of things, and we could find any maternal. So here the BP, maybe she's abrupted. It has just suddenly increased. Maybe the
that possibility is there. There's sudden shooting of blood pressure.
And we can actually send the placenta for histopathology also, the entire, and we can find out if there is any cause.
The second question, Pradnya.
Yes.
Does the rate of stillbirth increase in a post-dated pregnancy? Should you wait till about 40 weeks or more than that? in a low risk
So,
pregnancy?
as we all know that as we reach term, the liquor amniotic fluid, it decreases significantly. So to wait or no is a call which has to be taken. It is a patient to patient. It cannot be. So if there are no high risk factors, the Bishop's is very poor, you have done a biophysical profile and everything is good, then definitely you can wait. But if there is any problem, like there are NST changes, there is oligohydramnios or any other risk factors, and the Bishop's is good, then I think you can go ahead and induce a section depending on the. Also,
That's all.
if you suspect, then a Doppler, color Doppler of the baby can also guide whether
Yeah.
the flow is adequate. You can continue till 41 weeks.
Thank you, Pratna. Now over to Dr. Lakshmi Shrikande to introduce the next speaker.
Yeah. No, but Madhuri, you want to
Sorry, they want
Madhuri?
to discuss something more because these were the only
Madhuri
two
wanted
questions.
to announce how we select the best paper or at the end of this paper?
Geeta will tell now. Geeta, can you say?
Yeah, okay. The topic has to be very relevant to the times that we are, or it should be something that is pertaining to the government policy in the past 1 or 2 years, or what is going to come in the future. Like in the COVID years, the best papers were given to the papers which had data of the largest number of COVID patients. So that is one, the topic, the relevance of the topic. And secondly, the number of patients enrolled. That is also very, very important. Pradnya's, entire year had a lot of patients enrolled. So it gave us better data. So number of patients enrolled forms a very important part. And then how the study is conducted, ethical committee permission, like everything has to be there to the T. So that is a third thing. Statistical analysis is the other one. And whether the discussion and the conclusions are really giving a message for the practicing gynecologist. That is the most important thing that we see when we decide a paper for prize, whether it is giving a proper message or whether it is giving a proper information, the number of patients in the statistical analysis, and
Yeah, there is one more question for Geeta. Somebody has asked for a perimortem C-section, that is attendance consent is necessary for the same, because they are saying mortality on one side is a different issue and otherwise moribund condition of a neonate is a different issue. So could you take a consent or you just go ahead without doing it? That's what is the question being asked.
verbal consent to tell them.
Consent.
Verbal consent.
Always.
Always. And an
Always.
assistant has to be there to take consent. Relative will the mother dying.
Always. So Madhuri, can I go ahead and can I have the CV of Dr. Vidyashri?
Before that, I would like to congratulate Pradnya
Yes.
for the best paper. At the same time, she presented it very well, and she has given very clear message to everybody that the medical diseases like hypertension is a very common cause of stillbirth. And in the past, when we were resident in the junior consultant, we used to admit even blood pressure of 130/90. But now I'm seeing the trend that they are treated at home, and then they are called, if your BP is so high, you just come and get admitted. So we have to be concerned about this patient, that they require in the initial phase only the proper treatment. If you give proper treatment, we can pull that patient to the term as well. We can have a good neonatal outcome. I was always wondering that diabetes is a major cause of stillbirth, but now it has shown the reversibility, that now we are screening all the mothers for the diabetes at the first visit at 24 to 28 weeks and 32 to 34 weeks. So we are finding the stillbirth rates are very less nowadays with the diabetes, because all of a sudden you will get diabetic babies, their mothers, their babies die. And there are clear protocols also, guidelines also, that if a patient is only on the medical nutrition therapy, diabetic mother, gestational diabetic mother, then you go up to 40 weeks, no problem. But if they are on the medical treatment of like insulin or metformin, you have to deliver at 38 weeks. And if they are 4 kg plus, That is our government guidelines say that you should proceed with a C-section. So there are multiple medical causes Pragna has pointed out, and the PIH is the most common cause. So we have to take it very, very seriously and treat this patient. And she mentioned also in her paper that majority of the patient had 3 antenatal visit plus. So that is also again we have to introspect ourselves, okay, whether we went wrong somewhere, what happened, so many visits, and still outcome is not that good. So we have to introspect that. And of course, macerated stillbirth, we have to look into it, okay, whether we could have avoided or not. So Pragna, it was a very good paper, and you have given a nice message which Geeta said, okay, what from the government point of view and what from our point of view we can improvise the outcome. So this is the way we have selected the paper, Geeta has said. So congratulations once again. And Sujata, Lakshmi and Krishnandu, you can go ahead with the second paper.
Yeah. Thank you, madam, for your kind words and always encouraging.
Congratulations, Pradnya. And now we go to the second paper, that is by
Before you all go to second paper, I just wanted to congratulate Vidyashri Pujari for a very nice paper. And I have read that before, though I was not there for earlier discussion, but very nice paper. And I just heard your discussion. Wonderful discussion was happening, and I want to congratulate Dr. Madhuri Patel for a wonderful initiative that she has taken for this clinical pearl. That way we get the direct connect between the author who has done the work and with all the editors and everybody else. So thank you so much, Madhuri. It's going to be really very useful to all. Thank you.
Thank you, Suvarna, and I'm really happy that today my 3 editors emeritus have joined, CN sir and Geeta and Suvarna. So I'm really happy, and other national editors and the other editorial view. So thank you very much.
All the best, Madhuri, and all the best to the webinar. Thank you. I may come back again. Yeah.
So may I have the CV slide of Dr. Vidyashri? So we are moving ahead, and she is presenting her paper on we need to improve prenatal screening practices in primary obstetric care, representative data from a fetal medicine unit in coastal Karnataka. So Dr. Vidyashri, may just, I would like to introduce her formally. Yeah. Yeah, so I am so happy that she is our FICOG, and she has done her undergraduation from Mangalore, post-graduation from Kolar, and since 2021 she is associate professor in the Department of Reproductive Medicine at Manipal, Karnataka, and currently she is member of Kasoga Endoscopic Committee, and she has received awards, that is FOGSI Imaging Science Committee Award and JOGI Journal's Best Paper Prize Junior category. So congratulations, Vidyashri, and we all are eager to hear your paper, the award-winning paper.
Thank you very much, madam.
Vidyashri, you can start sharing your screen.
Yes. Is it visible?
Yes.
Yes.
Okay. So at the outset, I would like to thank the organizers for giving me this opportunity to present my prize-winning paper in the junior category in the second place. And this was, the study was done when I was an associate professor in the Department of Obstetrics, where we have a division of fetal medicine, but we do a lot of advanced fetal medicine treatment there, but we wanted to see the ground reality and what is the primary obstetric care in our referral population. So this paper was based on that. And the paper was published in March 2021. And the authors were myself, Dr. Sangamitra, Dr. Akhila, Dr. Anjali, Dr. Murlidhar Vipai, who was the head of the department at that time, and Dr. Pratap Kumar. A pregnancy outcome heavily depends upon the diagnosis and referral to a primary obstetric caregiver. And the prenatal detection rate of fetal abnormalities ranges from 17 to 85%, depending upon the study settings and the risk profile of the study population. While managing the referral to fetal medicine unit, we observed several deficiencies in the timely diagnosis at the primary care level. We performed a retrospective review of our fetal medicine referrals, especially looking for a representative data on the prenatal screening practices at our primary obstetric care in the referral population. So this was a retrospective study for 2 years in the year 2018-19 to our referral center from the coastal Karnataka. So each case was reviewed and reasons for referral were broadly categorized, and pre-existing risk factors were identified. 20 weeks was taken as an important gestational age parameter for the referral in this study, this being the legal upper limit of the MTP Act at that time. So for each structural fetal abnormalities, we reviewed the literature to note the gestational age or a range of gestational age at which the abnormality should almost always be diagnosed. And taking this as standard, the gestational age at which each of these structural abnormalities were diagnosed and referred was noted down from the case record. The delay in diagnosis, if any, was noted down for each of these patients. For those with delayed diagnosis, we collected the following information from the case records to know the reason for delay. The number, type, gestational age at fetal ultrasound done in that pregnancy, as well as aneuploidy screening at the primary care level, if any. The information was gathered on invasive testing and the result. The final perinatal outcome was also noted down in order to assess the impact on the perinatal mortality and morbidity. Many patients were referred back to the primary care center and were followed up the pregnancies for the neonatal information from the referral doctors. So a total of 277 cases were referred to the fetal medicine division over a period of 2 years. Mean maternal age at referral was 27.9 years. Out of 277, 117 were primigravida and 107 were multigravida. 228 cases, that is 82%, were not found to have any contributing risk factors for fetal abnormality like age more than 35 years, consanguinity, relevant obstetric history, any teratogenic drug exposure, infection, or any relevant family history. So of the 277 referrals, the structural abnormalities were found in 200 patients, that is 72%, isolated soft markers in 61 patients, that is 22%, chromosomal or genetic abnormalities in 7, 2.5%, and twin-related problems in 9, 3% of the patients. This is the overall flow chart, a little busy slide, but what we concentrated was on the structural abnormalities with which had 200 patients, and isolated soft markers were in 61 of patients with referrals, and a minority of them were genetic abnormalities and twin-related referrals. We did not consider these chromosomal abnormalities and twin gestation as the numbers were very small, and we proceeded with analyzing the structural abnormalities as well as the soft markers. So the next table shows the major system involved along with their gestational age at detection or referral. So this was the detection of the anomalies. So the central nervous system abnormalities were 44, and we categorized them as those detected by 14 weeks, and those detected before 20 weeks, and those detected after 20 weeks. So this 20 weeks was an important cutoff for our analysis at that point of time. So central nervous system abnormalities, out of 44, 8 were diagnosed by 14 weeks, 23 were diagnosed by 20 weeks, and 13 were diagnosed after 20 weeks. CVS 23 were diagnosed, out of which 1 was diagnosed by 14 weeks, and by 20 weeks, 14 were diagnosed, and 8 were diagnosed after 20 weeks. Out of the renal abnormalities, 9 were diagnosed before 20 weeks, and majority of them, that is 30, were diagnosed after 20 weeks of gestation. Even the GI system, 17 were diagnosed beyond 20 weeks. Musculoskeletal abnormalities, 5 were diagnosed by 20 weeks, and 12 were diagnosed by 12 weeks. Facial abnormalities, 3 were diagnosed before 20 weeks and 2 after 20 weeks. So multiple abnormalities, 2 were diagnosed before 14 weeks, 7 by 20 weeks, and 7 after 20 weeks. So what we have analyzed is every system we have analyzed whether they were able to diagnose by 14 weeks and refer to us, or by 20 weeks, or there was a delay in diagnosis. So as you can see here, many of them were diagnosed after 40 weeks of gestation. And we have represented 2 common gestational age windows at which most of the fetal abnormalities should almost be diagnosed. The data on how many anomalies were actually diagnosed in these gestational age windows are given, along with the data on delay in diagnosis. So the next picture will tell the timeline of the perinatal diagnosis in the referral population. The perinatal outcomes in each group are shown as MTP before the legal limit of 20 weeks, miscarriage, intrauterine death, stillbirth, neonatal death, live birth, and cases lost for follow-up. This was the table which shows a total of 200 patients with structural abnormalities, out of which anomalies almost always detectable by 14 weeks or the first trimester screening, it should have been 79, out of which 26 were diagnosed by 14 weeks. And there was a delay in diagnosis in 53 patients. The detection rate of abnormalities, which should have almost always be diagnosed by 14 weeks, the detection rate was only 33%. Of these patients who were diagnosed, 24 of them underwent MTP, 2 of them had abortion, and the anomalies which should always be diagnosed by the 20 weeks of gestation were 180, and which were actually diagnosed by 20 weeks were only 94, with the detection rate of 52.2%, and there was a delay in diagnosis in 86 patients. Out of those diagnosed by 20 weeks, 63 patients underwent MTP. The live birth on follow-up were on 17 patients, abortion in 2 patients, intrauterine death were nil, and neonatal death were in 3 patients, and 9 patients lost follow-up. The anomalies which may be detected after 20 weeks of gestation due to the natural progression of the disease were 20, and a total number of fetuses with the diagnosis beyond 20 weeks were 106. So this was the major delay. So out of 200 referrals with structural abnormalities, what I've told, the detection rate was only 33%, and in majority of the cases, the first trimester screening was missed, and that is why the early diagnosis of the anomalies were missed. When it comes to second trimester, 90% belong to that category, which should have been diagnosed by 20 weeks. However, only 52% were diagnosed in that category. But what we found was that though there was a delay beyond 20 weeks, the average delay in diagnosis was by 3 to 4 weeks beyond 20 weeks of gestation. So the patients which were diagnosed after 20 weeks, majority of them had an anomaly scan in the primary healthcare center was between 20 to 24 weeks. And that is why the referral was after 20 weeks. So the fetal abnormalities, which are variable in presentation during the pregnancy, leading to the diagnosis in third trimester due to their natural progression. And those were GIT abnormalities like bowel obstruction, renal problems, congenital diaphragmatic hernia, and CNS abnormalities may be diagnosed after 20 weeks of gestation. So in our study population, 106 patients had diagnosis and referral beyond 20 weeks of gestation, which accounts to 53%. So the average gestational age at mid-trimester anomaly scan in this group was 20 to 24 weeks. In our referral population, the obstetrician referred to radiologist for an anomaly scan, which is mostly done in the mid-trimester. As per the patient hospital records, the mid-trimester anomaly scan was done beyond 20 weeks among 45% of the patients. That is 125 out of 277 of our study population, which seems to be the reason for the delayed referral. And substantial proportion of these delayed anomaly scans were performed between 20 to 24 weeks. So out of 125, 104 patients had an anomaly scan between 20 to 24 weeks. So those which were diagnosed after 20 weeks of gestation, there were live births in 53 patients and the babies are on follow-up. And there were 2 IUDs and 15 neonatal deaths and 36 were lost for follow-up. We could not find any information on what happened to those pregnancies. So coming to the isolated soft marker, 61 patients were referred due to isolated soft markers, and 80% of them, that is 48, did not have any aneuploidy screening in their pregnancy, leaving us with an only age-based risk factor for further modifications. So the couple found it very difficult to decide on further options, especially those referred beyond 20 weeks. So as you can see in the flowchart, 31 patients were referred before 20 weeks and almost 30 were referred beyond 20 weeks. And coming to the those patients which were referred before 20 weeks, three patients underwent MTP, in which one had an abnormal karyotyping and 2 underwent MTP elsewhere without any confirmation tests. And 26 babies were on follow-up, in which 16 had normal results on invasive testing and 10 had no invasive tests, and all of them were normal at birth and are on regular follow-up. 2 were lost for follow-up. Those referred beyond 20 weeks were 30, and babies on follow-up were 25, and only 2 underwent invasive testing, which were normal. All other 25 babies were normal and are on regular follow-up. 4 lost for follow-up and 1 had an unexplained IUD. Coming to the discussion, advanced prenatal diagnosis is now available due to high-end ultrasound machines, 3D, 4D multiplanar interpretation supplemented by rapidly advancing technologies in prenatal genetic diagnosis. Internationally trained accredited fetal medicine specialists are now in India who can perform advanced therapeutic intervention. However, any beneficial impact on perinatal health indicators would depend upon the prenatal screening practices at primary obstetric care. We attempted to retrospectively analyze the prenatal screening practices, taking a small sample of 2 years referrals to the tertiary care center in our hospital. The commonest single prenatal screening modality available to the general obstetric population is the targeted mid-trimester anomaly scan, ideally performed between 18 to 20 weeks due to the restriction laid down by the MTP Act then. However, this essential screening practice was not provided to almost half of our referral population at the timely intervention. Despite the availability of international and national guidelines on mid-trimester anomaly scanning, prenatal screening practices do not seem to be highly effective in India due to heterogeneity in antenatal care delivery as well as lack of awareness among the people. Primary obstetric caregiver, either in the public or the private sector, refer women to a radiologist or less commonly to a trained obstetrician for mid-trimester anomaly scan. So there seems to be a lack of standardized protocol with respect to gestational age at referral. There is a great heterogeneity in the level of training, experience, expertise, and the protocol of anatomical survey followed by these sonographers. And the real-time efficacy of mid-trimester anomaly scan in India. In the present study, 53% of the 200 structural abnormalities and almost 50% were isolated soft markers diagnosed beyond 20 weeks of gestation. It is important to note that only 20 of these 106 belong to a category which may be detected in the third trimester. For example, those with congenital diaphragmatic hernia, congenital pulmonary airway malformation, bowel atresia, etc. The remaining 86 are the structural abnormalities which were almost always detectable by 20 weeks. For example, those with anencephaly, holoprosencephaly, common arterial trunk, double outlet right ventricle, bilateral renal agenesis, cleft lip palate, limb body wall complex, heterogeneity, and multiple anomalies. Most of the fetal anomalies occur among the low-risk population. Upon referral to fetal medicine, advanced imaging, multidisciplinary input, cross consultations, invasive diagnostic procedures, and further planning would take 1 or 2 weeks. So there are several modifiable factors at the primary care level, that is gestational age at the first antenatal visit, advised on mid-trimester anomaly scan by the obstetrician, the patient compliance to the doctor's advice, appointments available for mid-trimester anomaly scan, the patient load, overall awareness among the doctors as well as the general public. Unfortunately, the delayed prenatal diagnosis increases the possibility of late terminations, which in turn invites risk to the mother's life. They also contribute significantly to perinatal morbidity, mortality, including probably preterm delivery and long-term disabilities and health sequelae in the children. Our data show that delay in performing mid-trimester anomaly scan is more of a problem than a poor sonological detection rate. So majority, that is 83% of delayed mid-trimester anomaly scan were being done between 20 to 24 weeks in our referral population. This gestational window seems to be preferred by the sonographer for fetal anatomical survey as well as to do fetal echo. Organ development is near complete in this gestational age window. Poor sonological window due to factors like maternal obesity is less troublesome at this gestational age. So Savla et al. In 2012 also published a retrospective review of pregnancies diagnosed with fetal anomalies from District Maternity Hospital in same geographical area of coastal Karnataka. And similar to our study, majority of the fetal anomalies were in low-risk obstetric population. Among those who had antenatal checkups before 20 weeks, only 26.4 had mid-trimester anomaly scan before 20 weeks, and 1/3 of the affected pregnancies had their anomaly scan delayed beyond 28 weeks in their population. 8 years later, we performed the prenatal screening practices in our population and had not improved significantly in this same geographical location yet. So in a retrospective study performed in North India in 2015, 209 out of 312, that is 66% of the population, had major structural abnormalities detected beyond 20 weeks of gestation. Half of them had their anomaly scan only after 20 weeks, and in other half, anomalies were missed during the mid-trimester anomaly scan, which were done before 20 weeks of gestation. Like in our series, most of their patients were referred beyond 20 weeks from the primary care level. Utilization of 11 to 14 week scan. So among the fetal anomalies which were almost always detectable in 11 to 14 week scan, only 33% were detected in our study population. Among the delayed diagnosis were anencephaly, holoprosencephaly, megacystis, limb body wall complex defects, and multiple malformations. The detection rates are similarly low in the earlier publications involving low-risk population performed without adherence to the strict protocol in the primary care levels. A substantial proportion of non-detection at 11 to 14 weeks, that is 45 out of 53 cases, 85% in our study population, was due to non-performance of 11 to 14 week scan rather than missing the anomaly. Hence, 11 to 14 week scan is not used optimally in our referral population, despite the availability of expertise and good socioeconomic indicators in this part of the state. Similarly, Kashyap et al. Reported a very low 1.6% detection rate for 11 to 14 week scan from North India in 2015. There is a need to increase the awareness on the potential benefits of 11 to 14 week scan among the primary obstetric caregivers. Our first aim should be to achieve 100% coverage for an 18 weeks mid-trimester anomaly scan. Only later we can aim at achieving a good coverage for 11 to 14 week scan. A detailed first trimester survey should, however, be offered to high-risk population. A good 11 to 14 week scan requires accredited sonographers currently available only in secondary care levels, tertiary institution, corporate sector, reaching only a factor of our obstetric population. Coming to the aneuploidy screening versus soft markers, in our series, a good number, that is 30 out of 61, were detected to have isolated soft markers in mid-trimester anomaly scan performed beyond 20 weeks without having had any form of aneuploidy screening before that. Juggling with the likelihood ratios based on the age-based a priori risk is inaccurate, and this only increases the parental anxiety on aneuploidy and not giving them any clear-cut options for further testing. Many even requested termination without further testing due to uncertainties. If only one prenatal screening can be done to all, it would be better to combine a quadruple test along with mid-trimester anomaly scan at 18 weeks. This strategy gives a close to 80% anomaly detection, aneuploidy detection, along with a good detection rate of major structural abnormalities. So to conclude, psychological impact of prenatal diagnostics must be borne in mind, and normal finding in ultrasound results in joy and psychological well-being. In the absence of appropriate pre-ultrasound counseling, like in our country, parents go through a much emotional turmoil while receiving the bad news. Parents are unable to support a severely disabled child in the absence of social and financial support, and these decision dilemmas are further exacerbated due to late diagnosis when the mother has already felt the fetal movements and thus emotionally bound to the developing fetus. Many couples have approached the court with a writ petition to allow for late terminations in case of lethal severe anomalies diagnosed beyond 20 weeks, and our data strongly supported the need for implementation of proposed amendment to the MTP Act 2020 during our publication of this article in JOGI. And we are happy that there was an amendment in the MTP Act which allowed the termination for lethal anomalies and also extended the gestational age for termination. Using advanced ultrasound technology, many more fetal abnormalities can be diagnosed between 20 to 24 weeks when compared to 18 to 20 weeks mid-trimester anomaly scan. And advanced genetic testing like chromosomal microarray, clinical exome sequencing have enabled us to diagnose fetal abnormalities with dismal prognosis. However, such genetic testing takes a minimum of 2 to 4 weeks after the detection of structural abnormalities in mid-trimester anomaly scan. And safe abortion methods have substantially reduced the morbidity related to the MTP in mid-trimesters. And thank you very much for this opportunity.
Vidyashri, it was an excellent paper. Just my query is that in those 8 years, I mean, what measures you have taken to make aware your referral OBGYNs as far as the importance of anti-scan is concerned? Or even after your study, I mean, just theoretical question, how we can make them aware the importance of the anti-scan, which should be done at 11 to 14 weeks. Even if they don't know how to do it, at least they can refer to the fetal medicine unit. They can tell the patient, Baba, anti-scan, where majority of the anomalies, even structural anomalies, are diagnosed at 11 to 14 weeks.
Yes, ma'am. So this study was a period of 2 years referrals, and we have done a lot of talks through the Manipal OBG Society to the primary health caregivers, to the primary centers regarding the importance of NT scan, anomaly scan, and timely referral to our center so that we can counsel the patients better regarding these anomalies.
But it is really sad that on one hand, our fetal medicine science is advancing. We are doing intrauterine therapies, and on other hand, even our primary OBGYNs, they, don't understand the importance of NT scan. So these are two different scenarios as far as
there are some couples who have approached to the doctor even beyond the first trimester. That is also a possibility in some of the referrals. So late approach to the primary health caregiver and then referral to us. So that was also a scenario.
Can I say something? I would Lakshmi, that we rely very heavily on NTNB and dual marker, Quadruple marker comes into picture unless patient has not come at a proper time. So, and in case we find some abnormality, then maybe we could go in for an NIPT and later on maybe anomaly or an amnio. So we have lots of leverage, many days, many weeks to figure out what exactly. Plus even the patient and the couple also gets time to think, when you tell them at the last moment, they literally go into a panic mode. So from our side also, NTNB dual marker plays a very important role, and of course anomaly to add on to that, but we start off with that.
Yes, so we are really lucky that our government has amended the MTP Act, and now a couple can go for MTP up to 24 weeks of pregnancy. It's a really boon for our couples. Krishnendu, you want to say something?
No, I think you all have said it all. It's a very, for me, I was just putting down in a chat box that it's a really wonderful learning experience. And these papers, which will highlight it. And of course, we heard Pradnya, and then, Vidyashri is from Manipal, and where I've spent so much of my time of my life there. And it's amazing to see someone from Manipal doing so well. And I'm so proud of my alma mater. So, and I think, this 11 to 14 week scan, which Lakshmi was highlighting, that it's so important that, still there are so many generalists who don't give importance, and we miss that. And then we are kind of thumping our heads when there's an anomaly scan, something comes up. So I think we have to really emphasize that and move forward. And what else to say? A wonderful learning experience for all of us. Great show, Madhuri, fantastic. Well done.
We are really lucky that our Secretary General FOGSI is sitting here, because this is only a segment, coastal Karnataka, but I am sure many of the periphery OBGYNs or many of the OBGYNs, they are still not aware about the importance of 11 to 14 weeks. So Madhuri, we have to do a lot at FOGSI level to educate them, to make them aware ki baba karo 11 to 14 weeks and 18 to 20 weeks. These are the two scans which should be done on each and every pregnant woman, not only high risk woman, because she only presented that even in low risk woman they got so many problems.
Absolutely.
So I think we have to just think what we can do at FOGSI.
Yeah, Lakshmi, you are absolutely right. We have a perinatology committee, chairperson who is doing excellent work, and we had recently in the Pondicherry one conference also. So we are making our OBGYN, sensitizing them, making aware, and they have to do. But what happens majority of time, we have to make the patient aware because they come to us after first trimester. So I am very much surprised at what Vidyashri presented, that she found GTT positive after beyond 20 weeks. So now the government of India's guidelines says that you have to do as early as in first trimester and then 24 to 28 weeks. So it is basically obstetrician should be also aware. And secondly, the awareness amongst patients is very, very important. So we have many FOGSI activities as a Secretary General. Last year we had a Nana Anemia Yatra that created also very good impact, that we want to treat anemia. whatever prevalence of anemia was there 30 years back, it has still remained now also. So we used to do morning community services, we used to do examine the patient, we used to collect the blood, and we used to make the community aware about the anemia. Then evening we used to have a press conference with the journalists. So they used to spread again message. So they are also very, very important people to spread message amongst community. And in the late evening, we used to do updating about the anemia to our members. So we have to work in that manner that we can sensitize our community that yes, these are the things can happen. So I'm really surprised about the GTT that so many things are coming up after 20 weeks when you are performing your GTT at 24 weeks of pregnancy. So there also we have to make them aware. And as far as first trimester and second trimester screening are seen, I have experience. I do in my patient whether they are low risk or high risk. Whether she has rightly pointed out that in a low risk patient also you get so many patients with structural anomalies and other things. So I screen both that trimester. I screen not only for anti and dual marker, if they're negative, still I screen for the second trimester, including quadruple marker and the malformation. I have a very interesting case that she was 35-year-old patient, multi-para, but she conceived with the infertility treatment. And what happened at first trimester, she had a normal dual marker and the anti-scan. Second trimester, she had normal structure, anomaly scan was normal, but her quadruple marker came out to be positive. So we subjected her for amniocentesis and we did a microarray. And there was some problem in the genetic. And then the fetal medicine person, I refer to the fetal medicine person and advise for the parental, chromosomal anomalies. So we went for that, stage for the parents. Mother was negative, father was having same anomalies in his genes. So we understood that the father is surviving, father is having no problem, so that this baby is also not going to have problem. But still, we counseled the parents and they said they would like to continue the pregnancy. So I'm very happy that government has amended the law of 24 weeks where we can diagnose so many patients, and when they are not compatible with life, we can definitely ask for the termination of pregnancy. I remember one more patient of mine at 20 weeks, we did a structural anomalies. Before that, everything was fine. And in the third trimester, the congenital diaphragmatic hernia came there, and she lost her baby after delivery because it becomes very difficult to explain when they're 28 weeks plus and they have to deliver. But then the patient and the husband were very upset. Okay, doctor, why we have not diagnosed when we have come to you for so many antenatal clinic, we have done all the tests which you have said, but I lost my baby. And you believe me, they stopped coming to me. So this is very disheartening for us that we are taking so much of pains, still something goes wrong. So that is not in our hand, but with the 24 weeks amendment, I think we can do justice to our patient as well as the babies who will be lifelong, handicap. We can give justice to them. So this is, my excellent two presenters have presented so well. I'm very much impressed. And not only presentation was good, but their papers were all good. And now you understand that the awards they were given were to the actual people who have done this study. So this is adding to our clinical knowledge, okay, how to go about. And that's why we named as a clinical pulse of Yogi. We want authors why they have done this study and what outcome and how you should spread to the other people. Because journal also, I believe that we sent to all 43,000 members, free of cost, we printed journal with the idea that they read something, because many of them are not, digital savvy. Many people have internet problem. So I said COVID time we stopped printing the journal, but I felt that in an area where the rural area there, when the internet is a problem, at least, they can read these articles, they can update themselves and they can benefit to our patient. So I'm really happy to have this, my first webinar, which is, I feel it is very, informative to all of us. and we will continue to do this. It will be happening on every third Wednesday of the month between 4 to 6 p.m. If the time permits, then I would also like to have one case presentation, but I think the time will, if it is possible, we'll keep the presenter ready with the case presentation as a third case, and we will include. Initially, I thought we'll not have a case presentation, but the way everything is moving, I feel that sometimes we will also have a case presentation, and I want inputs from everybody how we can improvise and make this clinical pulse of JOGI more popular. Thank you everybody for joining over here. I must appreciate my editorial team, national corresponding editor, my senior, Dr. Purandare, Dr. Adidastu, Dr. Geeta, Dr. Suvarna, my national corresponding editor and chairperson who have joined today, and other delegates who have joined for making this a successful program. And I wish all of you come every third Wednesday. Please mark in your calendar now onwards that every third Wednesday, and I want inputs. So if your inputs are there, we can always improvise. And of course, my secretariat, like both the other Pragna is now in the editorial team, but Pragna, Gaurav and Sunil, they are also doing the excellent work, and they have really worked hard. Pragna, Sunil, both the Pragna, Sunil, and Maria, they have really worked hard for this webinar to become a success. So I also thank them for doing favor to me, and I wish they will continue to do all the work from on the editorial team. And of course, Sujat is our next. She's associate editor. She's going to be our next editor-in-chief after me. So I also wish her best luck. Thank you, all of you. Anybody wants to have any comments? It is
Thank
open.
you.
Any
I
other
must
comment?
say, Madhuri, it is an excellent initiative. First time from JOGI side that we have come out with these pearls, and the award papers are being presented by the original, the author himself or herself. That is a great thing. It will really help our OBGYNs to understand, and it will motivate them to document their data, to present their data, to present their original work in our journal. So fantastic initiative, Madhuri,
And
fantastic.
there are many youngsters, they would aspire from this, presentation.
Yes.
And, they would like to repeat the thing, research. And, so far in the journal, we used to have only talk about a research methodology, which is very important. But I felt we should start something clinically, which will really help all of us. So any comment from anybody, we are welcome. Otherwise, we have done with the day. Thank you, everybody.
Thank you, and thanks for the opportunity, Madhuri. It's wonderful.
Thank
you so much, ma'am.
Thank you. Well done, Pradnya. Well done,
On
Vidya.
behalf of my co-presenter, Dr. Vidyashri, and we would like to thank FOGSI President, Dr. Jaideep Tang, Secretary General and Editor-in-Chief, Dr. Madhuri Patel, Madam, Chief Guest, a guest of honor for today, Dr. Jaideep Tang, Sir, and Dr. C.N. Purandare, Sir, the previous Editor Emeritus of our journal, so who have been the past Editor-in-Chiefs, Dr. Suvarna Khadilkar Madam and Dr. Geeta Balsarkar Madam also, who have joined here today, and they have given, and of course the chairpersons for the session, Dr. Sujata Darvi Madam, Dr. Krishnendu Gupta Sir, Dr. Lakshmi Shikhande Ma'am, who have given their valuable inputs, and also mainly the people who have attended the program who actually make it a success. It has been a very interactive discussion, and we all dream to have our papers published in a national journal, and to present them to everyone is like the icing on the cake. So I'm very sure it will inspire more and more authors. And I would like to say that this will encourage all of us to keep proper records and publish them, because we don't lack data. If we compare ourselves to foreign countries, we have more patient number. It is only the task of collecting data, compiling it and publishing it, and then getting awarded and presenting is like a dream come true. So thank you so much, ma'am.
And I
Thank
would
you
like
very
to,
much.
Pragna, I would like to add my mentor, Professor C.N. Purandre, is still logged in, you know. So he is a
Yes.
great teacher when he was there in a Grand Medical College. We have learned so many things, and I must say, my teacher used to take every Wednesday for the postgraduate, you know, classes free of cost to his clinic, with from 7 to 11 p.m. So we have a great teachers over here, and Stir is still there. So I'm really blessed, and I'm really happy that when Sir can do so much of work, why can't we do? And so thank you, Sir. Thank you for everything, and once again, thank you all of you.
Sir has been inspirational,
Thank you.
and I would like to put on record that Maria from JOGI has really worked hard to bring this program and make it a success. She has done all the groundwork, and thank you, Maria.
She has done lots of work, I must say, that everything, means without we asking her, she was keeping everything on the table. And then we used to tell her that, yes, it is right, you have to do. So, Maria, thank you once again. And,
Thank you so much, ma'am.
Yes. Dr. Mitra, I think you're